Hi, I'm Dr. Twasim and welcome to my derm classes. Today's topic is identifying basic lesions in dermatology. So, this is one of the topics which are foundational and which quite a people struggle with, both the undergrads and postgrad, including myself, struggled when I started with my training. So, identifying the skin lesions are very important as a one step towards diagnosing the clinical condition. Is this just enough? No. But is this required? Very much. Due to which, a lot of the textbooks that you read in dermatology always begin with a chapter where you have an introduction about the basic lesions. But most of the people are very confused on what do they mean. Some, when they see the description of the macule, papule, they get so confused on what they mean and how to identify these. So in this lecture, I basically intend to bring a clarity on what are these lesions and how can you identify these lesions and how can you interpret them. These are important not only for interpretation. When you discuss or report a skin lesion to a colleague or a professor, it becomes very clear on how to do it. So let's get started. So when it comes to diagnosis, you need to know two things when it comes to skin conditions. One is its morphology and second is the topography. So the morphology is how the lesion looks and what are the basic characteristics, and the topography is how the lesion is distributed. So these are the two important things which helps you to diagnose. Are they just enough? No, you also need to consider a lot of other things, but this is one of the important cornerstones when it comes to the diagnosis. So let's start with the morphological classification. You have got primary lesion and secondary lesion. So what is a primary lesion? A primary lesion is a lesion which is present from the onset of the disease. So when a disease starts, what is the lesion that you see on the skin? So most of the cases, the people or patients come to us in varied stages of the diseases. Some can be in the onset, some can be in the at the end of a couple of years or a couple of months. So the onset of the disease where the skin lesion that is present is called the primary lesion. So not in all cases that we get to see the patients with pure primary lesions. So in most cases, it'll be patients who have tried treatments on their own or who have tried and consulted other dermatologists or consultants. So in that case, probably what we are seeing is nothing but the secondary lesions. So the secondary lesions can be because of over time the changes that a disease undergoes, or it can be because of the medications that the patient applies on them, or it can be because of the manipulation. So these all can lead to the secondary lesions. Let's move in detail. What are the primary lesions? So these are certain terms that's been introduced as a primary lesion. So these are macule, patch, papule, plaque, nodule, vesicle, bulle, pustule, and wheal. So when it comes to these different definitions, you should be very clear on what they means and what they stand for in order to define this is a macule or a patch or a papule. So one of the such characteristics is the size of the lesion. So when you consider the size, certain lesions, when it's less than 1 centimeter in size, you call them one name, and when it's more than 1 centimeter, which is larger, you call it a different name. So for example, macule is when a lesion is less than 1 centimeter. Now what's a macule? We'll see later. And the same macule, when it becomes more than 1 centimeter, you call it a patch. Similarly, a papule is a lesion which is less than 1 centimeter. When it's more than 1 centimeter, you call it a plaque. Similarly, vesicle becomes a bulla when it's larger. Pustules are generally less than 1 centimeter, and the nodule is more than 1 centimeter. So another question will be, what if it's like 1 centimeter? So that's generally considered as less than or equal to 1 centimeter. You call it the smaller lesion names. So let's get started. So the main idea of learning about the basic lesions is you should be able to diagnose them in a clinical scenario. There is no point in learning a lot of theory if you're not applying them in the clinics, isn't it? So which is why I have adopted this particular technique where I would like you to pause the video for a second and look at these clinical lesions and see what are the changes. Basic questions that you need to ask is, what are the changes that you can see in the pictures from the normal skin background? And another thing that you can compare with these images, are these the same? Are they similar in any manner, or are they different in any manner? When you take the time to think about something, it reflects in you more rather than when you learn continuously. It's not gonna help you in any way. So just pause the video for a moment and just see what is the things that you can identify. And whenever you're ready, just replay the buttons and let's get started. So when you see these images, you can see 4 images in front of you. So let's start with the first image. What you can see is there is an increase in pigmentation from the background skin. try and also identify what is their skin type like. So this is probably an Asian skin, a darker skin type. So it can be from skin type 4, 5 or 6. It seems to be somewhere in skin type of 5. And what you can see, there is an increase in the pigmentation. And second thing I would ask is, can you differentiate between the normal skin and the abnormal skin very clearly? Yes, isn't it? So this means it's a very well circumscribed lesion which is hyperpigmented, and it's a lesion on the face. Let's go to the second picture. Here you can see like it's a Caucasian skin mostly, and you can see there is some less diluted pigment. So the dilution of the pigment is either called as a hypopigmentation, or when there is absence of pigment we call it depigmentation, like the ones we see in vitiligo. So in this lesion you can see some hypopigmented to depigmented spots that's been scattered in the skin. So that's something that you can see. Now let's move on to the third image. What can you see there? You can again see a hyperpigmentation. Yes. What else? Can you define the boundaries? Yes, it's very clear. So it's a very well circumscribed hyperpigmented lesion. Let's move on to the fourth image. What is that you can see there? You can see there's a dilution of the pigment. Either it can be hypo or depigmentation. I feel it's a depigmentation. That's all we can say. And is it well circumscribed? Yes, I can draw a line very clearly. So it's well circumscribed. So these are the lesions. Can you see any elevation in the lesions? And a picture is not, from a picture to interpret whether a lesion is elevated or not is not that easy. But you can't see any elevation at the moment. Yes, so among the primary lesions that we have studied, which can be this? So that is something that you need to think about. So these are flat and circumscribed lesions with a different color from their background, isn't it? So this is nothing but a macule. So you call it a macule when the size is less than or equal to 1 centimeter, and you call it a patch when it's more than 1 centimeter. So the examples that's been given in the previous image is lentiginous freckle, melasma, idiopathic guttate hypomelanosis, and vitiligo. Which is something that you can go back and try to figure out yourself. It can be considered as a homework. And when you try to describe these lesions, you need to say the shape, the diameter, the color and border. Why? It's very important when you document it medically. And also it's very important when you talk to your colleagues or professors about the skin lesion. It becomes very clear in their mind what kind of a presentation the patient has come upon with. So let's try and describe this image. Here you can see 4 clinical scenarios. And what's the starking difference from the previous image? This seems to be an elevated lesion, isn't it? From not that flat. And what else can you see? It is something where you can draw the boundaries very clearly. So it's a well circumscribed lesion which is elevated. And what about the color that you can see? The first one seemed to be skin colored, and the second one and the third one seems to be more of erythematous, and the last one seemed to be hyperpigmented, isn't it? So let's try and define. So these are elevated. Is the elevation from the epidermis or dermis? It can be both. We never know. Sometimes it's more clear. Sometimes it's not. It's a very circumscribed. Yes. And the elevations are, or the elevations same in nature? No. Some are umbilicated as we saw in the first picture. Some are dome shaped or flat shaped. So this is nothing but a papule or a plaque. We call it a papule when it's less than or equal to 1 centimeter, and a plaque when it's more than 1 centimeter. So the examples that we saw in the previous images, seborrheic keratosis, molluscum contagiosum, psoriasis and sarcoidosis. And again, when you try to define, try to say the shape, the diameter, the color, the border, the topography, and this if it's from an image. But if it's from a clinical scenario, you can even feel and say how the consistency feels. Is it hard? Does it feel like a juicy or a plaque-like, and all those. So all plaques are tend to be elevated except in the case of morphia, which is again a clinical condition. The picture I have not included, but you can go back and read about it. But all the rest of the cases, the plaques will be elevated. And when it comes to a papule, there is, depending on how they look on their top, like the lesions, it can be pointed, it can be rounded, it can be thread-like. So this can be divided into acuminate, dome-shaped, filiform, flat-topped, oval or round, pedunculated, which means it has got a stalk, sessile, which is without a stalk, which can be umbilicated, as we saw in the pictures, or it can be verrucous or warty. So these are all the different classifications of a papule. So when you try and define a papule, try to identify any of these topics that you can see in here. Coming to a plaque. A plaque is again what we defined as more than 1 centimeter elevated lesion. This can vary as an annular, arcuate, polygonal, polymorphic, serpinous. serpiginous, or poikilodermatous. Again, this varies with each lesion. So you can go and read more on what can these lesions signify as a diagnosis. So now let's try and identify the clinical image in here. As you can see, this lesion seems to be elevated from the background compared to the previous ones. And can you see any change of color? Yes, the first one seemed to be a bit more red or erythematous, and the second one seems to be of skin color, but on the sides you can see a bit of redness. So these are the two lesions that you see in now. So these are elevated, and these seems to have a well circumscribed nature. So when they are elevated, well circumscribed, this can either be arising from the dermis or it can be arising from the subcutis. The second image that you have seen is an ectodermoid cyst. What if I add a feature of these are better felt than seen? So this is nothing but a nodule. Now let's interpret this clinical image. Here you can see there are two lesions, two clinical images where you can see there is some fluid collection and it seems to be within the epidermis, isn't it? So these are actually clear fluid filled lesions in a background of a bit of redness and scaling. So what can this be? So when it's elevated, it's circumscribed. Now it's filled with a clear fluid. It can either be filled with hemorrhagic or serous. What do you call this as? So this is nothing but a vesicle when it's less than or equal to 1 centimeter, and a bulla when it's more than 1 centimeter. And where do these lesions occur? For example, varicella zoster, which is commonly called as a chicken pox, or it can be bullous pemphigoid as we saw in one of the images. So this is again one of the primary lesions that you need to know. Coming on to the next clinical image, let's try and define what you can see in this image. So in this image, what you can see is that there is an erythema or redness you can see, and it seems to be an elevated lesion, but we never know. We need to see in clinical, in real clinics, not just the photographs. And you can see it's partially defined. You can say it's fully defined, but it seems to be partially defined, elevated, well circumscribed lesion, isn't it? So what if I say it's a transient elevation? Does anything come to a diagnosis? So this is for example, when it's a transient elevation with a pale center and erythematous rim, we generally call it an urticaria. So that's a clinical condition. So what is a primary lesion in an urticaria? So that's called as a wheal, which again is very common to see in the clinics. Coming to the secondary lesions. Secondary lesions, as we told, these are the lesions that evolve over time due to manipulation or treatment or the disease progression. So these can be a crust, scale, fissure, excoriation, erosion, atrophy, lichenification, or infarct. So some of these lesions you might have already heard about, okay? So let's see what these different secondary lesions are. So coming on to this image, what can you see here? You can see that there is it seems to be a lesion around the lips, and you can see there is some crusts lesion. So what are the crusts? It seems to be some dried up serous discharge that you see near the lips. Along with this, what you can see is there is a bit of redness, and you can see a bit of erythema, isn't it? Erosion. You can see some of the skin underneath. So what is this? So this is dried up serum or pus of blood. So this is a case of infected eczema. So what do you call the secondary lesion? It's called as a crust. Coming to the next lesion. As you can see here, it seems to be an elevated, well circumscribed lesion. So this can be a plaque, as we saw in the previous images. But on top of this lesions, you see something that is white, and that is something that is white that's stuck on the top, kind of an appearance. So this is nothing but a scale. So scale is a visible accumulation of the keratin. It is because of the excess stratum corneum. Either it can be because of increased production, like as you see in case of psoriasis, or it can be because of a delayed shedding. So, but the scale is really important because the characteristic of the scale defines what clinical condition it can be. So it can be silvery in case of psoriasis, it can be furfuraceous in case of pityriasis versicolor. If it is a greasy scale, it's more of seborrheic dermatitis. If it's gritty, it's actinic keratosis. Gritty means you gotta feel those scales, and it's polygonal, it's more of an ichthyosis, okay? Now let's see what is this secondary lesion. So here what you can see, it's a sole being shown in the image, and what you can see, there are some cracks, and there is more of cracks basically in the back of the heel. So what are these? So these are linear clefts in the skin, and what if the patient also says that it's very painful? It's something again that you commonly see in your clinic. So this is nothing but a fissure. And coming to the fissures, this can also be seen in hand dermatitis. So what are these now? So you can see it seems to be a lesion beneath their neck. There is a background erythema that you can see around, and what you can see is there is a loss of skin from some area in the center, isn't it? So this is injury to a part of the skin, and these lesions can be linear or punctate, and here it seems to be a punctate. So this is nothing but excoriation, which generally happens because of immense scratching when the lesions are itchy for the patient. So it's a loss of epidermis or portion of dermis due to scratching or exogenous injury. You call it an excoriation. Now, what are these? You tend to see pretty much a lot of things that's going on in the skin, isn't it? You can see some pus-like lesions. You can see some raw areas. You can see some denuded skin. So, what can be the secondary lesion here? So there is partial loss of the epidermis, and this is nothing but pemphigus vulgaris. It's a clinical condition. So what I'm trying to demonstrate as a secondary lesion here is nothing but the erosion. So erosion is a partial loss of the epidermis. Coming to the next clinical scenario, what can you see here? You can see there is a loss of skin, isn't it? As simple as that, and it seems to be in depth, especially in the base of the big toe, isn't it? So what can this be? So it's a full thickness loss of the skin, including the dermis and the subcutis. So here you can see the floor and the base, and also you can see the edge. So this is nothing but an ulcer. Generally, ulcers occur as a part of stasis ulcers, which occurs as a part of varicose veins, or it can be because of pyoderma gangrenosum, where you get a violaceous hue around the ulcer, which is classic. And let's see the next secondary lesion which you're trying to define. You can see the toes in the image, isn't it? And you can see something that is black. What does indicate a black? Black indicates it's a devitalized tissue. And how can it be devitalized? Probably because it's not getting a blood supply. So something has happened that has disrupted the blood supply, resulting in a devitalized tissue which appears to be black. So what do you call it? So ischemia and gray-white areas occur in the case of infarct. So a most common condition that you can see is antiphospholipid antibody syndrome, where you get multiple infarcts. Now, let's see the next secondary lesion. What can you see here? It seems to be an abdomen of a patient. And what you can see is that you can see some linear lesions, which is there at the base of the abdomen and the sides as well. And how are they different from the normal skin? You can see some wrinkling of the skin, isn't that? Yeah. And when you look at the lesions right across at the back, you can see some depression from the surface level. So you see a bit of a wrinkling and the depression. So what can this be? So this is nothing but an atrophy. So the atrophy can occur from the epidermal atrophy or a dermal atrophy. If an epidermis is getting atrophied, it mostly presents as wrinkling. And if an atrophy occurs from the dermis, it mostly presents as depression, which is what you can see at the back of the image. Probably you need a real clinical patient to appreciate it more clearly, but this is what we can do from an image. So this occurs in the case of striae or in the case of lichen sclerosis. Now let's see, what can you see here? This seems to be it seems to be the front of the ankles. There seem to be a hyperpigmentation, isn't it? That is very striking. Now let's take a closer look. What else can you see here? You can see that the skin markings seem to be increased on the front of the ankles compared to the leg and the feet, isn't it? So it's hyperpigmented. There is an increased skin markings as well. So what do you call this? It's called as lichenification. It's generally due to the rubbings where there is accentuation of the natural skin lines. It usually happens in lichen simplex. Then coming to the distribution. So we talked about morphology and distribution. So entire part of this lecture I dealt with was just the morphology. Now let's move to the topography. So when it comes to distribution, this is something that you need to learn and understand. So if particular lesion is distributed in this place, it's more likely to be this clinical condition. So I've put out a table for you to read through and understand what can be the different distributions pointing towards the clinical diagnosis, like if it's acral, if it's asymmetrical, if it's dermatomal. So that is one of the basic things that we know. If it's a dermatomal distribution, it's more likely to be herpes zoster or likely to be varicella. It can be generalized. It can be distributed to just the flexures, it can be just in the extensors, it can be just in the hair follicles, it can be around the follicles, which is called as perifollicular. It can be generalized, it can be widespread, it can be localized to one particular area. It can be interdigital, it can be intertriginous, which means between the folds of the skin, like an axilla or in the abdomen, abdominal folds. It can be linear. There can be a dermatomal distribution that we already told. So these are the different topographical distributions which you need to know about in order to identify a diagnosis. I'm not going in detail. This is something that you can pause, read about it, and learn more. So next is, what are the additional things that you need to look upon? So apart from the colors that we have already talked about, was one was erythema or redness, and the other was the black color that we saw in an infarction. There can be colors like yellow if there is pus. There can be colors like gray in case of Pseudomonas infection. It can be green, sorry, in Pseudomonas infection. So these can change just like that. So you need to interpret and give a complete conclusion on what is the size of the lesion, shape of the lesion. Is it a macule, patch, papule? What are the colors that you can see in the primary lesion? And then what are the secondary lesion that you can interpret? And all together gives a complete idea on what the skin lesion that you're seeing, and from then you can diagnose based on the distribution as well. And you can also make this interpretation or document it somewhere, or you can present it to a professor. And I think this brings to an end of the discussion today. And let me know if that's all you need, and in case you need any additional information, please leave a comment below. I can do further topics on that. Thank you.